Welcome to Healing Voices Project, where we share stories of addiction, grief, recovery, and courage. And also from people who work every day in the field of substance abuse who discuss their experiences and advice. I'm Mike Torville, your host. Thank you all for joining us. Good morning, everybody. Thanks for coming back and joining us here at Healing Voices Project. Today, we have a very special guest, an expert in the field of addiction and substance abuse disorder. We have Dr. Peter Friedmann from Baystate Health System. And Dr. Friedmann has been a doctor in Springfield practicing for over 34 years. Is that correct?
I've been in Springfield actually 7 years. I'm coming on 7 years.
You've been practicing for...
I've been practicing longer than I care to admit.
we won't do the math on that. And over the past 15 years, Dr. Friedmann has authored over 138 articles and participated in numerous clinical trials. And I have an introduction here that's probably going to... I have to read it, and I apologize because it's too long to memorize. But currently, you're a Chief Research Officer at Baystate Health, Associate Dean for Research at UMass Chan Medical School, and also Professor of Medicine, Professor of Population and Quantitative Health Sciences at UMass Chan Medical School. And among the many professional societies, leadership roles, Dr. Friedmann is the Editor-in-Chief of the Journal of Substance Abuse Treatment and a past president of the Massachusetts Society of Addiction Medicine, along with several significant honors and awards. It's safe to say that I think you can provide some expert information here on this topic today.
I'll do my best.
Thank you for coming here. I know you're very busy, and I really appreciate you taking time. Because what we're about here is sharing stories, sharing information, creating awareness, and also trying to reduce the stigma in many different ways. And this is why talking to people like yourself, and people who share their stories to inspire people. But also, what we found is a lot of people don't know the information that could be useful to them, and how in real everyday life, what might change, and how we share the right information. So I think today we're going to dive into some of that here. And I first got to know of you through your interview with Senator John Velas several months ago. And I thought that was great. And Les and I spoke and said, hey, you know what? This is great information for our audience. So I appreciate you taking time.
It's a pleasure to be here.
Thanks. Now, I think, we're going to dive into these topics, but I have to ask you to start off is, what got you started in this field? What made you choose this area of expertise versus another area of practicing medicine?
Yeah, like many things in life, it's your influences, and we can get into how other people influence your behaviors in life, maybe as we talk about this topic. But for me, it was sort of my close professional colleagues. A lot of them were doing this work when I was a fellow in Boston. Actually, one of my very close colleagues who recently passed, Dr. Richard Sates, and I shared an office. He was doing a lot of work around alcohol use disorder. I had actually, in my residency training, I trained in Montefiore in the Bronx during the AIDS epidemic, and I was very much interested in HIV, and that was what I wanted to study. But one of the things I noticed in my residency is I was very much interested in HIV, but all of my patients were more interested in answers around what to do about their cocaine problems, because it was also the height of the
back then
cocaine epidemic, and I didn't really have answers. I didn't learn anything in medical school about it. Really had very little in residency about it at all. And then I became exposed over the course of my fellowship to folks who were doing this work, and then I became engaged with an organization called AMERSA, the Association for Medical Education. Well, it was the Association for Medical Education and Research in Substance Abuse. I think it has since changed its name to the Association for Multidisciplinary education and research in substance addiction. We can talk about why the language has changed, perhaps over the course of today.
Sure.
But a lot of very influential mentors and others in my life sort of brought me and welcomed me into this field. And then, in my first job, when I went to the University of Chicago, I was all hot to do HIV work. And for reasons of stigma, the university at the time was not it was not delivering those services. That was really viewed as the work to be done at Northwestern, which had at Cook County. And so I was sort of stymied in my research interests. And a mentor came from the University of Michigan who had a big NIH grant in drug abuse, and so I went in that direction.
You said for reasons of stigma, they didn't offer that, but you went into another area that's has a stigma to it as well. And
it's interesting. I mean, back in the day, HIV, this was before, all the now I think it's less so because we have treatments which have turned it into a chronic illness that people can live a full normal life with.
Right.
But this was before, this was a long time ago. And it was very different, and it was a fatal illness and was very scary. And so a different time. And some of it has to do with personalities as well, like everything else in life. It's who are in the positions of making decisions, and what decisions do they want to make for the practice, for the clinic. And this was not in their cards. And so I went in a different direction. And I'm glad I did, because it's been a wonderful career.
you were out in Chicago and other areas, but are you from Massachusetts originally?
Actually, originally from New York.
Okay.
I grew up on the North Shore of Long Island in a town called Great Neck. And my first job out of fellowship was in Chicago. And it was really very formative in this field. I had the opportunity to work with some real major figures in this area. Tom Diano, who led the National Drug Abuse Treatment System Survey, which really established what are the current practices around the treatment system around the country. Got to work with Ed Sinay, who was a mentee of Jerry Jaffe, who was the first drug czar, and was the first person to bring methadone to Illinois. They founded the Illinois Drug Project, which brought methadone. It was the first place outside of New York, as you're probably familiar. Methadone was first investigated at Rockefeller in New York, and then the first program outside was in Illinois. And then with Dean Gerstein, who had actually just come from the National Academy of Sciences, had just written the major report for the National Institute of Medicine called Treating Drug Problems, which was sort of the first major look at the treatment system and some of the quality issues that they identified. Unfortunately, many of them still persist, but so a lot of very influential people in my life.
And over those years, to say it's sort of an obvious understatement to say you've seen a lot of changes is pretty obvious. But I'm thinking particularly in the last 3 years or so, just pre-COVID to what we've learned over the last few years, the changes you've seen, and I'm sure there are many, but I'm thinking about what have we learned in the past few years, the changes that you've seen, and the changes from the cocaine to heroin to harder drugs and now the fentanyl problem. What have we learned that has warranted changes in the way we, in programs and practice and policy, particularly in the last few years?
Yeah, I mean, it's been more than in the last 3. I mean, during COVID, I mean, we've learned a lot about the treatment system during the pandemic, particularly around the care of folks on medication. So folks on medication, the methadone regulations are very restrictive because of concerns about transmission. Within clinics, they were loosened, and the sky did not fall down. Right, people did fine, and now there is discussion of making them permanent. There's movement in that direction. We also learned that telemedicine is a great way to engage people. So there are a lot of things we've learned recently. But what I've seen over the course of what I would say is the last 20 years, really, sort of the growth of the opioid epidemic, is there's really been a sea change sort of in the view of the role of medication in the treatment of this disorder. I mean, I remember early in my career, in the late 90s, giving a talk at the there's a National Academy of Drug Court Professionals. I remember going out in Nashville and giving a talk. It was actually in the early 2000s, and basically being about the benefits of medication for the treatment of opiate use disorder, because the data was very strong even then. And being basically booed off the stage. That has changed dramatically. I mean, that is one thing that has changed dramatically, is sort of the view and the importance of medication as part of treatment of this disorder. Now, we can talk about the other substance addictions. We don't have quite as dramatic medication benefits, but I often think of this as a family. I talk about this as a family of disorders, or you can use the word disease. We can talk about disorder versus disease.
I do want to talk about that. Yes, yes. Yeah.
But I think of it as a family of disorders, kind of like, you think of cancers as a family of disorders. There are blood cancers, there are solid tumors, and the treatments are different, right? The treatments that you use for leukemia are different than the ones that you use for breast cancer. Mm-hmm. And even though they have sort of similar pathology, the overproliferation of cells, the way you approach them is different. And it's the same for when you're dealing with alcohol, or you're dealing with cocaine or methamphetamine or opiates.
And for listeners who, just to clarify, when you're talking about medications, you're talking about methadone, Suboxone, Vivitrol, medications like that, and when they're used. How do you determine, if somebody's listening and they don't know, well, when is one used versus another? And why would you say, okay, we're going to put you into a methadone program versus something else? How does someone who's not an expert in this know the difference between those?
Well, so I really believe that if a person has concerns about this disorder, they need to get an assessment and have a consultation with somebody who understands the difference. I mean, the way we manage them is different. So buprenorphine, or the brand name is Suboxone or Subutex, is the way it's regulated is different from methadone. It is available to give in the office. So typically, folks who are able to sort of manage their medication and have, within the American Society of Addiction Medicine, we sort of talk about the recovery environment. So if it's relatively stable, they have a place to live, they have a place to store their meds safely, and they can take their medication each day. Usually that is, by and large, the first line treatment. Methadone is a much more, the regime around methadone is much more structured. So you have to go to at least early on.
Structured and supervised.
You have to go into a program every day. There's certain required counseling. There's certain required urine toxicologies. There's, there are certain requirements that you have to do. And that's often for people who have a more severe disorder, or who require more structure in their life. The Vivitrol, or the injectable naltrexone, is interesting. My view of this is really for really, really highly motivated people who don't want what's called an agonist. So they really want to lose the try to have their receptors come back to a more natural state. And but the problem with that is, it's an injection. People don't like injections, and the experience with it has been that people tend to drop off it pretty quickly. Because there's no withdrawal. If you come off Vivitrol, there's no withdrawal, there's no consequence. There's no feeling of it, so people either forget or they stop it, and then if they find themselves in a triggering situation, they're not protected. The other problem with it is you lose your tolerance, and we can talk about that and why the loss of tolerance is such a problem for overdose. When you lose your tolerance, if you use, people over time they develop tolerance, so they need more and more of whatever it is.
Any
Nowadays,
substance,
now on the
whatever,
days on the street, it's fentanyl. It's all fentanyl. People call it heroin, but it's really fentanyl. You need more and more of it to get the same effect, and that's the development of tolerance. Goes along with withdrawal when you stop. And if you detoxify people and put them on Vivitrol, what happens is they go back to square one in terms of the amount that they need. So if you needed, 100 grams to get high today, you'd go back to 10 grams, right? But if you happen to take 50, you say, oh, I'll cut what I used to use in half because I want to get high. And you've lost your tolerance, that's when you overdose, because you've lost your tolerance.
It's like a shock to the system.
It is, and in a lot of jails and prisons, that's been a problem, and why, the data show that rates of overdose, when you look at compared to sort of age-matched adults, people leaving prison have 120 times the rate of overdose of other people in the population, because they've gone into jail in most cases and they've been detoxified, and then they come out and they use, and boom, they overdose.
And their tolerance has changed.
Their tolerance has gone down. Now, fortunately, in our state, in our Commonwealth, there has been a lot of movement in the jails and prisons to make medications available, which is great. And I've been very involved in some of the evaluations of that work. But still, around the country, that is not the standard. There's still a lot of places where people are coming in and being taken off.
This leads to a topic that I've been reading about, and I know you and Senator Vilas talked about this, is about safe consumption sites here in Massachusetts or in New England. And there's been some recent progress. I want to talk about your feelings about safe consumption sites, but also what's the progress in Massachusetts right now with that?
Yeah, I mean, it hasn't gotten out of committee. I mean, they've had a bill for a number of years. My personal feeling is the data are very clear that it is a lifesaver, and it prevents HIV. It allows people to get safe equipment and reduce overdoses. So it has a lot of benefits. Mm-hmm. I often find myself in the situation where I have a patient whom I'm treating, who I know is continuing to use and use street sources, fentanyl on the street. And for them, every time they use, it's a crapshoot. Yeah, it really is.
It's like a Russian roulette, right?
Yep. Yeah. And if I was able to say to them, I understand this is difficult, to come off, and you're not quite ready, but please go to this place where you could at least do it. And if you get into trouble, there'll be a professional there who knows how to reverse it. There have been around the world. There have been millions and millions of injections done within safe consumption sites, and they've not had a single death. Not one.
Right, because Narcan's available, they can do it. Yeah, and I think in the beginning, I thought, well, is that going to encourage use? Is it enabling? But the more I've learned about this, the more I saw the other side and said, you know what, there's so many benefits to this. One, you're right, you can prevent overdoses, it's controlled, it's supervised, people have Narcan available. There's maybe some fear of it's going to be crime in the neighborhood because it's going to draw people in. But being supervised, controlled, preventing overdose deaths, but also averting other medical costs too.
Yeah.
The follow-up costs are greater. So I think in the end it actually saves a community money, maybe even reduce crime, certainly reduce overdose deaths.
It does actually.
Yeah.
The police in the areas that have them think it's a wonderful thing. It reduces syringe litter. It reduces crime. It reduces public use. I mean, people using in public. So disorderly conduct and those kinds of things. And it definitely saves lives.
And if there is a reaction, you have somebody there, a medical person, to take care of it.
Right.
Yeah.
And the other thing that's really underappreciated is so you have an opportunity to interact. So these are normally people who are sort of hidden out in the shadows, off by themselves. So it brings people into a place where they interact with others and they interact with healthcare professionals. There's an opportunity to counsel them, to talk to them about treatment and about safe use and harm reduction. And what they've found is many people go on, so that when they're ready for recovery, when they're ready for treatment, you can put them right in there. And so there really has been demonstrable ability to get people into treatment.
And I think if somebody did go to the safe consumption sites, and they've gone a few times, you're right, and it becomes there's a trust, I would think. They've established a trust with the people they see and say, hey, and you're right, maybe they can be exposed to some treatment program where they wouldn't be if they were doing alone. And I think, as we know, too, most overdose deaths occur when someone's alone. Having somebody with them can greatly reduce that.
Yeah, and what you call trust, there's a lot of literature on what's called therapeutic alliance. So a lot of change, a lot of behavioral change happens through the influence of other people. I was talking about my professional trajectory. The influence of others around me clearly influenced me, and that's true for everybody.
Mm-hmm.
Who, there have been studies that have shown that if you live with somebody who overeats, you're more likely to overeat. There's a lot of that sort of social network. So if you're taking people out of just a network of folks who are using in an unsafe way and bringing them into a place where there is, an emphasis on health and improving one's life, that does have an influence on people. And let me speak quickly to the notion that people say, oh, you're just encouraging use. Well, to me, the analogy is, saying like seatbelts and airbags encourage people to drive recklessly, which is people would never say that, So I really feel like it is a no-brainer, but from a policy perspective, it's been a very challenging hump to get over.
And I think, again, we talked about some of that resistance. Is it enabling? Is it going to increase crime? Is it going to increase costs for a community? But I think in the data I've read, it can reduce overdose deaths by more than a third. Mm-hmm. And just thinking about that aspect, I think it far outweighs those other areas of concern.
You want to keep people alive until they're ready for recovery. And frankly, if it were my kid, if God forbid, knocking on wood here, if my kid had this problem, I would want her to go to a place. I would want her to go to a place like this. And I know many of your listeners probably have kids who have these issues. You would want this for your kid to be safe. They're going to use in a safe place, keep them alive until they're ready to seek recovery.
And in Massachusetts right now, they're not available yet, but
they are not available.
Not yet. Working on it.
Not yet. They are available in New York, and there is in California. There are a couple around the country. There are some underground ones.
Okay, and there's one in Rhode Island, I think, that was opening, or at least
they will be opening in Rhode Island.
In Rhode
yes.
Island. Okay.
So I think it's coming. I think it's inevitable.
Mm-hmm.
It's really a question of how long.
And I think the more data, the more you hear, the more you see, because it's changed my mind, certainly. The more you say, well, wait a minute, there's a point of this that I didn't see before. And I think that the more people know, maybe some of that resistance will go away. We hope that. We'll see. We talked about a little bit, you mentioned it, and I do want to ask about this. The topic of calling substance abuse disorder a disease versus a disorder versus none of the above. And, okay, if it's a disease like other diseases, and further to that is, to someone listening, well, okay, what does it matter? What changes if you categorize it as a disease versus a disorder or something else?
Yeah, I often say that's a distinction without a difference.
Okay.
So, to be honest, the issue of calling it a disease has to do with whether or not healthcare professionals are going to get paid to deal with it, right? Doctors, nurses, counselors, mental health professionals get paid to manage disease, right? We don't get paid to manage social problems. So if you call it just a social problem, which there are people who used to or do, probably they're still
social workers.
Social, but they don't. But that's not. You wouldn't get paid to do that. I mean, my feeling about this: there are a lot of syndromes in medicine that we deal with, things that we don't fully understand the causes thereof, but we understand that they are dysfunctions in how people are in one or more area of life. And this happens to be one in which there is a clear behavioral pattern, which is well described in the Diagnostic and Statistical Manual, which is what we use to describe behavioral and mental disorders. And it has a neurochemical basis. So my feeling is the issue becomes, when people start out, there clearly is a choice that's made, or you're in a situation with peers or others. I've often heard this it's described as a disorder with pediatric onset. It's usually teenagers, experimenting, and as teenagers are wont to do.
Most often, yeah.
And then it sort of gets out of they don't appreciate the risks, and then it sort of gets, in some folks, depending on their environment, their background, their genetics, they lose control over, and it's really that loss of control over the behavior that really is the sine qua non, if you will, of the disorder. That it's so whether we call it, from my perspective, whether we call it a disorder, a disease, a syndrome, a diathesis, whatever your favorite term is, it doesn't really matter. The manifestations, in American Society of Addiction Medicine talks about the 4 C's. So it's the loss of control, the compulsive nature of the behavior, it's the craving, and it's the continued use despite consequences. Those 4 things to me sort of describe, at that point, it really is this. It fits the idea of a disease. But earlier on in the life, in the course of the illness, it behaves a lot like a risk factor, right? So, and so I often ask this question: is high blood pressure a disease? I don't know if any of your listeners have high blood pressure. I do. I take a pill every day for it. It's silent, so it has really no manifestation except when they check my blood pressure. It happens to
Do you
be
notice anything different if you stop taking it?
I notice nothing. Yeah, I do notice some things, but I don't know if I can talk about it on the air. But the medication has some side effects. Let's just say that.
Okay.
But so it is a risk, but I view it as a risk factor. It's a disorder of my, how I regulate my blood pressure. It puts me at risk for certain things, right? Risk for stroke, risk for heart disease, kidney disease, other things, right? And so I take medication to manage that risk factor. And so early in its course, addiction or substance use disorder, mild, manifests for me more as like a risk factor. It's like you haven't yet experienced consequences. You may not yet have craving. You may not yet have lost total control over it, but it's risky. Like what you're doing is risky. And over time, it may progress, but at every point, it is a risk factor and does merit attention and treatment from a professional.
Yes, and if you think about the adolescents using typically recreationally, right? Mm-hmm. And this is a choice that there was no reason for them to take other than peer pressure, recreational experimentation, and so on. And then it turns into an addiction, and then it becomes a problem, obviously, medical problem, the disease. But
yeah, I mean, it's fun. I mean, it's reinforcing.
Yeah.
I mean, I happen to drink. Occasionally I like a good cocktail. Many of us do. It is reinforcing, and for some people, anything that is reinforcing like that, one can develop a loss of control over that and this disorder.
Yeah. So,
and again, it runs in families for a reason, partly environment, partly genetics. There are some people who can drink moderately and do perfectly fine, and others who can't.
And I've had several guests and several friends and family members who said, I cannot go out and have a beer. One beer is not in the menu. It's finishing a case of beers. It's to the extreme because they just can't get past that. One beer triggers it all, and it goes. So
I think there's an AA expression about that. One drink is too much, and 10 drinks, or one drink is too many, and 10 drinks is not enough, or something like that.
Yeah, and it just goes endlessly until there's pass out moment, and that's the end. But it affects so much of your job, your life, everything. When you start off with the recreational use, and it's something I've changed my mind about, is, it shouldn't be a disease. How is it treated? It's recreational, it's choices. But I think about it, not all the time, but typically lung cancer starts off as a choice, the choice to smoke. And then it turns into lung cancer. Well, nobody's saying, you don't qualify for treatment because you chose to smoke. It's not that way.
I have a more stark example.
Uh-huh.
So skiing is a choice.
Yeah.
And when you break your leg, we don't say to you, you chose to ski.
Right. It's your own fault.
It's your own fault. It's risky,
Yeah.
Or any of these extreme sports, people, but there's risk in everyday life. People take risks, and this happens to be one that leads to a particular disorder, and we make these choices all the time, and we make distinctions about which ones are worthy and which ones are not. That's really
Yeah, and often the more informed you are, the more you can have I call it an opinion, but I've changed my opinion the more I've learned about this. And it's not always a choice because, it may, and often it does start off recreationally, peer pressure, and I've done that. I've experimented a little bit here and there. When I was younger, I like having a beer every now and then, and I can see, fortunately, knock on wood again, I'm not in addiction or in recovery, but in my family it exists. My grandfather was an alcoholic, and my aunt, his daughter, became an alcoholic, and also along with drug use, and she passed away a few years ago. So we've seen it up close and personal how it can manifest itself. But so I avoided that.
Yeah, so it's
Yeah.
not always a choice. I mean,
Yeah.
to your point, we hear stories all the time about sort of the intergenerational passing of the disorder. Parents who are using in front of their kids, um, alcohol as a major part of family culture.
Yeah.
If you're born into that, that's all you know. I mean, and it's not really you don't choose your family.
It's
right?
what you know. Yeah, yeah, exactly. Yeah. And there's something else that leads to. There's a couple things that's going through my head now. Is pain medication and dependence on pain medication, and how that can lead. That's not recreational use. It becomes, I call it a desperation, because I relate to my own experience with that. Is for example, in the book I had written called Voices from the Fallen, there's a few stories of people who broke their wrist,
Yes.
ended up on pain medication, and then ended up taking heroin because the pain medication was no longer available. The OxyContin was no longer available from the doctor. They get it from the streets, and then that's run its course, and then the heroin takes over, partly because of the tolerance changes, and of course the cost. Heroin's a lot less expensive. But I'll take one case, for example, in the book. Person's name is Jeff in the book, and he's in his mid-50s. He hurts his back. He goes to the doctor, gets the Oxy, and he went to the doctor for a follow-up after a few weeks, and the doctor said, okay, I'm going to give you another prescription for the pain medication. And Jeff says, I'm fine. I have half a bottle left, so I'm good. And the doctor said, why do you have half a bottle left? By now, you should have taken it as prescribed. You should stay ahead of the pain, and you take it as prescribed. I'm going to give you this prescription. Well, okay, you're the doctor. I'll listen. Took it, and then as he took it as prescribed, when he ran out, he desperately needed it, and he needed more of it. And that led to getting it on the streets when his prescription ran out, and it led to him becoming a heroin addict. Mm-hmm. He wasn't an adolescent recreational user. He wasn't getting peer pressure. His body needed it, and he overdosed. He survived it, and his life was torn apart. His family was ripped apart. Everything happened because of it. And now those things happen frequently, too frequently. In my own experience, I've had knee surgeries, multiple knee surgeries, and of course I go home with your crutches and your bottle of Oxy. Mm-hmm. And I just went through this just 3 months ago, and when that was out, I'm like, well, I can handle this. I'm good. But at night, I'm dying of pain, mm-hmm. and I said, where's that bottle? I call the doctor the next day. I really need this. I feel desperate, and I just needed it. And I got it, and it ran its course, and that's the end of the story. But I get that feeling like I'm pacing in the middle of the night, mm-hmm. just craving for it. I'm digging, where did I leave that pill? I go, wow, it has that effect on you. And then you think about people that say they're on the street, heroin, and I want to talk about arresting and decriminalization and things like that, because you got somebody who's a pretty decent person. They're not a criminal. They're not breaking the law. They just developed a dependence on pain medication that led to heroin, and now they're arrested and they have a record now, and maybe end up in jail. So I just wanted to get your thoughts on the decriminalization of drug use and how you think the effect of that is, and where we're at with that.
Yeah, I mean, that's a great question. Yeah. There's just a ton in the story you just told.
I
know. As a medical doctor myself, I apologize, mea culpa. My profession has not been on top of this as much as, and frankly, the medical profession was very much influenced by pharma during the 2000s, the 90s and 2000s, around underappreciating the addictive potential of these medications, mm-hmm. and and that's as we know now, it was a deliberate marketing strategy. And doctors are subject to these things as just like anyone else. This is not a new problem. So there have been different waves of different opiate epidemics over the course of the last century and a half. Starting back after the Civil War, there was, with the development of the hypodermic needle. Actually, heroin was originally developed as a treatment for morphine addiction.
Was it something you drank back then, or was it?
No, it was injectable, but it was people had morphine dependence, and heroin was marketed by Bayer.
Wasn't cocaine part of the original Coca-Cola formula back then too?
It was.
Okay.
It was. These were there were a lot of things done. This was long before there was an FDA or any regulations, and so a lot of people, if anyone's ever seen the film Long Day's Journey into Night, it's about that. I recommend you read that again. You probably read it in high school. The mother in that case has a opiate problem. But so this is not a new thing. And we had flares in the 40s and 50s and 60s and in 70s. That's what brought methadone into widespread use. And so, the thing that's changed, so clearly the population affected has changed. Used to be considered an inner city problem. It was very racialized, and so there was very much a criminal justice. The war on drugs and things taken around that. Now that it's affecting white people and people outside of the inner cities, we're starting to view it differently. We can have a whole session about why that is, and about the racial history of this country. But the fact of the matter is that the idea that we can lock up our way out of this problem, I think we've established that hasn't worked, and that we really need more public health approaches. A number of states have decriminalized, possession. Oregon, in Portugal, other places, and I understand there is a bill in our legislature as well to do that. I do think it is the right approach. We should not be incarcerating people for use, and we really should be taking a more medical/public health approach to this. That's really, it's a disorder. It's and the idea that we lock people up for having a disorder is just unconscionable in my opinion. But there was a lot in your comments about, I just want to, because you use the term addict, and a lot of us in the field now are sort of moving away from that kind of terminology. I know it's still very much used in sort of the 12-step community. My name is so and so, I'm an addict, or I'm an alcoholic. But there really is a view now, and there's been some research showing this by my colleague John Kelly at MGH and others, that has shown that using less stigmatizing language it is a better way to go in terms of folks' view of the disorder. So I prefer to say, a person with an addictive disorder, or a person with substance use disorder, rather than talking about sort of addicts, alcoholics, abuse.
It does stigmatize.
All of these sort of stigmatizing words. There really, I think there is something to that, and there's been a lot of work going on. Actually, we at Baystate have a what we call the Words Matter campaign, which we did within the hospital, and it's changed the way medical providers talk about their patients, because the way you talk really does affect your attitudes towards people.
And affects their willingness of somebody to come forward. Right?
And it humanizes people to say this is a whole person who happens to have this disorder, rather than saying, this is an addict, this is a, or in older, this is a junkie. There are all kinds of words like that that are very stigmatizing that, people still use. And so we're trying to move away from that and use more person first, so thinking about the whole person, and more clinically appropriate language. So talking about folks who have substance use disorder, I think, is more to the point. That's rather than talking about substance abuse, which is very stigmatizing.
Yes, and I think too, people still, and it's starting to change, but have an image of somebody says they're a heroin addict, using those words. You get this picture of somebody in an alley behind a dumpster shooting up, and it's not so much that anymore. You have people in every level of affluence, every type of community, every race who this is affecting, and I think that's they're finding. And look at celebrities, people with living in mansions, or
well, I think the fact of the matter is it was never. That was always the stereotype.
Yes.
And as I said, it was very racialized and urban. It was never like that. But what we've seen in the current epidemic is folks, and you asked early on in this conversation, you asked, what's changed. I mean, people are now starting to see that, this is not a disorder that's just sort of confined to the inner city. It's really everywhere.
Everywhere, yeah. And it's hard to find a family who's not affected by this, whether it's friends, family members who does not have a direct connection to somebody who's going through this substance abuse disorder. And I know personally I've had many friends whose sons have died between 19 and 25 years old.
Terrible.
It's awful. And one of the things to talk about, I want to talk about the Good Samaritan law, because talk about the immunity of somebody who's maybe afraid because of several reasons. I mean, fear of getting arrested. And if somebody's with somebody and they're overdosing, they can call, and with this Good Samaritan law, they're immune to being in trouble with the law, right?
It's not as unfortunately it's not as effective as we would hope.
Yeah.
So you can't be arrested for possession for that incident. However, the problem is a lot of folks have outstanding warrants for other crimes or other things. And so there is often fear that if they call, they're going to be picked up on these other warrants. So there does need to be some modification of the law to sort of address that issue. But largely it has been effective in terms of getting folks to make the calls, understanding that they, themselves would not be liable for this particular
and the opportunity
event.
to save someone's lives by making that call, and not the fear. Because even in the people I've spoken with and interviewed, it's harsh, it's awful to say, but sometimes oh my gosh, are they alive? Did they overdose? Let's get out of here.
Right.
And let the police find them. That's horrible.
Well, I think the thing that is really life-saving is to get Narcan, naloxone, out into the community and have it widely available everywhere for people who are using, their families, and to be sure that they have the skills and readiness to use it, and to encourage folks never to use alone. And alone, people think of alone, oh, well, my family member is downstairs. Well, you're in the bathroom upstairs. That's alone. And it's, and fentanyl, the thing that's horrible, many things are horrible about fentanyl, but the time of response, it has to be so quick. The onset is so fast. People can die very quickly. So never use alone. Have someone else in the room. Have Narcan at the ready. If you can do a test shot, or if you can do have a fentanyl test strip to check your stuff to see whether there's any fentanyl in it. That's advisable. But at the very least, have someone else in the room at the time that you're using.
How does
and
somebody
have
get a
fentanyl
test strip for that?
So there are a number of the local syringe service programs do have fentanyl test strips.
Okay.
And you can, after you've prepared your dose, you can do a dip and see whether or not there's fentanyl in there. A lot of folks are recommending that. 90+% of what's out there now is fentanyl. If you're buying heroin, that's fentanyl.
That's fentanyl. Yeah.
The other thing that is really, really dangerous now is there is a lot of stuff that is out there as cocaine or pressed pills, Xanax, other things that are really fentanyl, that are counterfeits with pressed fentanyl. And we're also seeing folks die, and those are risks because those folks saying, "Oh, I'm not using heroin, so I don't need to have a Narcan kit nearby." But even cocaine and these other things, pills, nowadays, if you're buying it on the illicit market, you need to be careful because it could have fentanyl in it.
That is so scary. It's
terrible.
Unbelievable. One of the things that's come up often too, and again, it's something I've changed my mind about. I've changed my mind about a lot of things over the past year or so. More I learned about this is in a lot of families I've heard this too. Well, they're using and let's say they're referring to a family member. They're using and we've tried everything. I guess they've got to hit, and the term that's coming, rock bottom, before they can get to treatment. So they'll sort of just wait for that rock bottom to hit, and I've thought about this so much that is so dangerous. And rock bottom often is something you don't come back from, because it's a rock bottom could be death, especially with what you were talking about with the so much fentanyl out there. And rock bottom is different for everybody, but at what point do you allow your family to be more torn apart, your finances to be wiped out? Why wait to rock bottom when you've potentially destroyed your life? The more you can intercept it, the earlier you can intercept it. And to me, there's zero reason to allow this to happen to rock bottom. I don't know what your thoughts are on that.
Yeah, I mean the notion of having to hit bottom that's from the 12-step tradition.
Yeah.
As a clinician, I see people all the time who, for various reasons, will seek care and have not, had a dire. When you think of rock bottom, you think of a dire consequence. So, like they're homeless, or they've had an overdose, or
there is nothing left for them.
They've gotten HIV,
or landed in jail.
Landed in jail. So. You don't necessarily have to have those things. People can change at any point. Sometimes it's just a question of holding a mirror up to them. This is what your life. This is what promise your life had. This is what you're doing. It is a disorder. We need to get help for it. Just like if you had cancer or you need to get help. You would never say, "Oh, I'm going to, treat my cancer going." I guess some people go to Mexico and get some crazy treatments for their cancer, but you should seek professional care for these things. 'Cause it's and encourage folks. This is a disorder. It is treatable, and people recover all the time. People do extremely, extremely well. Get their lives back. And you asked me early on how I got into this field, but what you didn't ask me is why did I stay in this field? and the answer has to do with reinforcement, since we're talking about addiction. And for me, what's been incredibly reinforcing is seeing people. I'm an internist, so used to be an incredible success was if your blood pressure went from 160 systolic down to 140 systolic, I was like, woohoo. But or if your sugars went from an A1C of like 8 to 7, that was a huge victory. But with this disorder, what I see as a provider is I see people totally turn their lives around, get their families back, get good jobs, start to have savings. I mean, you see people in their really in their fullest lives.
Mm-hmm.
It's as a clinician, it's incredibly rewarding. And I don't know how much longer we're going to go, but I just want to talk a little bit about one of my favorite papers.
Yes.
In the medical literature. It's a paper called The Clinician's Illusion. It's from 1984. It's written by a very well-known statistician couple, Jacob and Patricia Cohen, in the Archives of General Psychiatry. And they talk about disorders for which we have a biased pessimism about the prognosis, which is to say we believe that people do worse than they really do. And he talks, in the paper, they talk about schizophrenia, they talk about alcoholism and drug addiction. And the way this comes is like if you stood in the emergency department and you're a clinician, the cases that you see, is a bias in terms of the cases you see. You see cases of long duration, of high severity who are coming in with complications. And you're seeing them all day long. So your natural conclusion is, oh, these folks must do really poorly. Why bother treating them? Why bother? The problem is the people who do well leave your emergency department or your jail. It's the same in jails. Mm-hmm. They leave and they never come back. You don't see them again. So they're out of sight, out of mind. Whereas the people who do poorly, they keep coming back. They call them frequent flyers. There's keep coming back. And those are the ones you see. And it's a form of availability bias. It's a cognitive bias that you extrapolate from them to the entire population. And it's an illusion. It's an illusion. People, do extremely well. There are a lot of people who go off. For me, the analogy that I use is like if the only people with cancer that you ever saw were people with metastatic stage 4 cancer, you would conclude, oh, cancer is incurable. There's no point. Mm-hmm. But you never see the people, with earlier stages in whom, you give them a word of encouragement or you suggest they go get care. And they do well, and they don't come back. So I for those of you who are clinically minded out there or work in clinical settings, keep this in mind. It is a real illusion. It is a real phenomenon. Folks, and if you do this for work, like I do in sort of more of an outpatient primary care setting, it's incredibly rewarding because you see people do extremely, extremely well and get their lives back.
Yeah, and that's right, and that's interesting, and I do want to read that.
It's a good paper.
Yeah, and I think it's really rewarding too to when we discuss it with some of our guests and people that we've had in the book Voices from the Fallen, to see how they've overcome and got their lives back. See families come back together. I mean, that's just an incredible thing that keeps you going. And same with this. If someone's listening and just hears about something that saves their lives, we may never know about it, but still, it can be very rewarding to hear somebody has a good success story as a result of something that you've said, so.
I hope so.
Yeah, well, I know we could talk all day, and I'd love to have you back. And especially with updates and safe consumption sites and other topics like that.
It would be my pleasure.
Thanks, yeah. Well, thanks everybody for listening, and especially to Dr. Friedmann for joining us, taking time out of your busy schedule. Appreciate your time, appreciate having you here. And everybody for listening. See you soon. Thanks.